Alright, so I'm going to demonstrate how to manage airway obstructions in paediatrics. I've considered my scene to be safe. I've got the appropriate PPE on, gloves and normal glasses. At this stage, I've got a 1-year-old male patient who has a partial airway obstruction. He's still able to cough, so I'm going to just keep encouraging him to cough. And at the same time, I'm just going to reassure mum and dad and advise them what's going on. If my patient was to deteriorate and progress to a complete airway obstruction, then I'll perform 5 back blows. So for him, he's a little bit heavy, so I'm going to lay him down and I'm going to perform 5 back blows. And that hasn't removed the airway obstruction, so I'm going to flip him over and perform 5 chest thrusts. And the airway obstruction is still not removed, so I'm going to perform another 5 back blows again. And then if I was unable to remove the airway obstruction and the patient progressed into cardiac arrest, then I would lay him down and start CPR, and I would get back up. While CPR is being performed, I'd want to remove the obstruction in his airway. So I would use my laryngoscope blade and I would attach the handle to it. I'd select the appropriately sized Magoo forceps, so I'd go Paediatric Magoo forceps. I'd make sure my suction is available and ready to use, which I've got here. I would make sure that I'm positioned behind the patient's head. They would be laying flat like that. And then I would make sure that they're in the sniffing position and open up their mouth, remove any dentures or removable plates as required, and then I would insert the laryngoscope blade into the vallecula with my left hand so that I can visualize the posterior oropharynx, making sure not to lever on the teeth, suctioning as required, and then I would grasp the forceps in my right hand with my thumb and the ring finger, and I would insert the forceps while they're closed into the patient's mouth on the right side of the laryngoscope blade once I've removed the tongue out of the way, and then I would grab the obstruction and pull it out, and then I would oxygenate the patient as required post removal and continue with chest compressions if the patient was still in cardiac arrest.